First of all, I want to thank the Cleveland Clinic for inviting me out here to speak. It's always nice to reach out to the community, give back the stuff that's stuck up in my brain in here and spit it out so it doesn't cloud me up too much. I think today's topic is something very important to everybody, including myself, and it's something that I have always treated with passion and fervor. And so before I get started in the lecture, I just want to let you know that usually after I give one of these lectures, a lot of people have questions because they hear something that I said or something that I might have shown on a slide, and they say, I have that, or I'm concerned about that. And normally I would stick around for hours and be happy to talk to anyone, but unfortunately I have to get back to clinic after this, so I can probably maybe take a few questions, but if I have to leave, I don't want anyone to feel like I'm slighting them. I'm sure Denise can actually, who is a great help here, Denise Marshall, who can help facilitate anyone getting a hold of me or needs to make an appointment or something of that nature. My background is I grew up in New Jersey, and I did my undergraduate work in New Jersey, and then went on to podiatry school in Philadelphia, which is now associated with Temple University. And then I went on to do my residency program in Cambridge Hospital in Massachusetts, which was a Harvard-affiliated program. During that time, I had not really been exposed much to neuropathy. And I started seeing more and more of it as I got into practice more and seeing people from all walks of life, all sorts of situations, not just diabetics, but people with other diseases that were considered neuropathic. And so I started developing a real passion for treating neuropathy because I realized very quickly that most of the information that you all get about neuropathy is from the drug companies. And that's very unfortunate because you see these commercials for Lyrica on TV or these other drugs that promote healing diabetes when you don't realize that a lot of these drugs actually have more side effects that are probably bad for you. And they actually cause you to have neuropathy. They do help with pain, and I think they do have their place. But unfortunately, there's just not enough education going on that is accurate. And there's something I'm going to mention today in my lecture that I think some of you may find surprising about neuropathy that I knew about 10 years ago. And when I tell you, and I'll make note of it, I think you'll find it surprising and you may want to tell some people. So I'm very excited to give this lecture. And as I go through it, if there's something you don't understand or I went too fast, just kind of raise your hand and I can certainly review it. I am here as part of the Foot, Ankle, and Hand Center of Las Vegas, and we have a couple of different locations, and we have a multi-specialty practice where neuropathy is certainly one of our main focuses. So let me see if I can get this thing working. And this is just a picture showing, what some people may feel with neuropathy, like they're walking on pins and needles, or you can take the opposite effect, they don't feel anything at all. They might walk on these pins and needles and develop an ulcer in their foot and never know it. So neuropathy, no matter how it is caused, is certainly something that you need to address and not just ignore. So what is peripheral neuropathy, which is really what this whole lecture is kind of based on? It is basically disorders arriving from injury to the peripheral nerve system. That is the Neuropathy Association's definition. And now, that can be from a direct trauma, like you're hitting something with a piece of wood or a soccer ball, or it can be trauma caused by your own body. So there's different types of neuropathy, which we can see here on the slide, which is sensory, motor, autonomic, or mixed. You can have all of them at once or just some of them. There are also mononeuropathies and polyneuropathies, again, meaning you can have one kind or both. And I'll talk about some of these as we continue on through the lecture. This slide's a little bit old, but not too much. We're now about at 30 million people affected by neuropathy in the United States alone. So that's a huge number, a very large number of people affected by neuropathy, and that's growing, and that's just in the United States. And the cost to the insurance companies and everyone is huge. And I talked about Lyrica earlier. You know, that drug is not cheap, and it's probably generating billions of dollars in revenue to these insurance companies, and it's not really actually curing anything. So one of the things that you might see when you have neuropathy, especially sensory neuropathy, meaning you get numbness and tingling in your hands or your feet. You have pain is more of a later stage kind of sign. Loss of protective sensation, and that sort of leads down the road of developing ulcers in your feet. You know, people lose sensation in their fingers too, but they don't get ulcers in their fingers. Why not? Because your fingers aren't walking on the ground. There's not that pressure factor going on. You might drop a glass, you might not be able to grip so well. Those things are caused by neuropathy. But in the feet, where it's special, and you're walking on bones that may be misshapen, whether it's flat feet, high-arched feet, those all are factors in whether or not you're going to develop problems as related to ulcerations. So you can be running around and falling and breaking a hip because of your neuropathy. You know, people say they have balance problems. Well, it's not always related to your brain necessarily. You could have neuropathy in your extremities, and this causes you to walk unstable, and you can't balance yourself, and so you wind up experiencing a fall, which leads to a fracture sometimes. So when you see motor neuropathy, what we see here with this gentleman is that his legs are pretty thin. And this is a specific kind of neuropathy that affects muscles. And if you have this particular problem, it can be progressive. And so you're going to need to identify this as quickly as possible so that you can treat it accordingly. Typical signs of muscle problems are, again, weakness, atrophy, where you see the legs getting smaller, and then cramping in your muscles. These are all signs of neuropathy. Now, there is some crossover with other things that could be causing these problems, for instance, vascular disorders, but very often people will come in thinking, oh, I have a vascular problem. I have PAD, as it is said now. And PAD is actually a nice term for peripheral arterial disease, but very often PAD will mimic neuropathy or vice versa. So you have to have them both looked at. And that's why I say it's deceiving. Patients often come to me and say, Doc, my legs are cold or my feet are cold. And then I will put my hands on their feet, and they're actually not cold. They're normal temperature. But the brain, because of the neuropathy, is perceiving their feet or legs as cold. And that's the neuropathy portion. So you have to really make that differentiation. And often patients will say, I feel like my socks are bunched up under my feet, even though they're not. Or they feel like blocks of wood when you're really bad and you've had neuropathy for quite a while. So again, as a physician, I want to listen to the patient and have them tell me, what are your symptoms, what is going on? And then once I hear that, I can usually make the diagnosis without having to actually put my hands on the patient. We do that when we need to, but very often the diagnosis is very easy by the history. Symptoms of autonomic neuropathy are things that occur in your stomach or your eyes, your cardiac muscle, all the smooth muscle in your body. So, you know, if you're someone who has chronic diarrhea or chronic stomach pain and you're neuropathic, you have diabetes, then this is something that can affect that. Also, sexual dysfunction as well is prevalent with neuropathy. So there are literally over 100 causes of peripheral neuropathy. You don't really see too many of them. You know, usually it's the top 5 that are seen on a regular basis, but there's a bunch of them. And every once in a while, someone might present with one that you've never seen before, and that requires further testing. But usually it's kind of the top 5, if you will. And one of the things that we have to be aware of is what is acquired, meaning you got it after birth, and what is inherited, meaning you got it before you were born. So if you have something inherited, it's eventually going to show itself most likely. And if it's acquired, it develops over time. Some are both. You know, diabetes has a genetic inherited component to it, but you might not get it later in life because you didn't eat enough cheeseburgers or donuts or whatever else that triggered it to occur. So of these peripheral neuropathies, about 1/3 of them are diagnosed as what's called idiopathic. Now I like to say it's idiot neuropathy. because I don't think that people understand what really is going on. I think probably only closer to maybe 15% are truly idiopathic, meaning you may not know what is going on. In the majority of the, quote, idiopathic neuropathies, it's actually nerve entrapment. What does that mean? I think we're all familiar with what carpal tunnel syndrome is. So carpal tunnel syndrome is when you have a nerve entrapment in your wrist, where the nerve is either swollen or the ligaments around it are crushing on that nerve. And so that's an entrapment. You can have an entrapment anywhere in your body, in your head, in your arms, in your legs, in your pelvis. All of these things can lead to symptoms that look like other things to other doctors who are not really well trained in neuropathy. And I can tell you, as sure as I'm sitting here in front of you, that every day, thousands of people get misdiagnosed with something else like a tendinitis or an arterial problem or just your everyday migraine headache, when the reality is they have a nerve entrapment that can be fixed, as opposed to going on a drug like Lyrica or narcotics or whatever the case may be. So I think as time goes on and that peripheral nerve specialty becomes more and more prevalent, I think we'll start digging into these things and seeing them a little bit better. In fact, where I trained in Boston, I was back there a couple of years ago, and for the first time down at Mass General Hospital, they had a peripheral nerve center. So they spent a lot of money on that, and so I think they understand the importance of it. And your inherited peripheral neuropathies, again, these are more severe types of diseases. You see here this person with these hand deformities where they have atrophy in their hands. They call this a monkey fist because it looks like a monkey fist. And this also occurs in the feet as well. These are, again, things that happen over time. And your acquired neuropathies, again, come after birth, and these are things like diabetes, leprosy, HIV and AIDS, cancer can cause tumors, Lyme disease, all these different diseases, vitamin deficiencies, your thyroid. If these are all not well maintained and certainly not acting how they're supposed to in your body, it can lead to neuropathy if they're not identified. Now, diabetic neuropathy, everybody's very familiar with that, and probably half of you probably have diabetes sitting here if you're at this lecture. Affects close to 10% of our population at this point. So it's really important that we address this and keep this going. But there is some sort of resistance by the American Diabetes Association to sort of not grasp onto certain concepts. And so while I think it's a great organization, I think there's room for improvement in how they view and treat people with diabetes, which I'm going to talk about shortly. Some other acquired neuropathies, again, treatment of those cancers that we get with the toxic drugs that are being taken, radiation therapy, and then certainly, as I mentioned briefly earlier, any kind of trauma. If you fall, you get an automobile accident, or even just doing repetitive sports can cause things like this. So we need to understand what causes, or what are the causes of these things that are causing these neuropathies. So pathomechanics basically means how the muscle or nerves are functioning. Is it something that is mechanical that is affecting the nerves? Is there a pressure point like carpal tunnel syndrome? Or is there a physiologic reason, as I mentioned earlier? Is there something going on in the body that's causing the nerves to become swollen, and when they become swollen, the canals that they travel through become symptomatic, and you start getting pain and the signs of diabetes. And that's why I have on the bottom of that slide there, swelling of the nerve. In fact, I think, when I click that little button there, I highlighted the swelling of the nerve. And that's really what happens in these nerve damage. In any form of neuropathy, the nerve becomes damaged. The nerve has its own little blood supply, which I'll show you here in a minute. Now, one of the newer things that has been coming out over the last 10 years or so and is becoming more prevalent is something called small fiber neuropathy. Small fiber neuropathy simply means the small little fibers. You have basically, if there's a small fiber, there's a large fiber, right? So large fibers have myelinated tissue around them, and they allow for conductivity really quick. The small fibers are the really old fibers that come into from our brain, from back when we were cave people, that tell our bodies when we're in pain or when we touch something really hot. But when they become damaged or diseased, it actually gives you pain, pain that doesn't go away no matter what you do. And so there's a test that we can now do for that, a very simple skin test, which is called epidermal nerve fiber density test. And what we see here on this slide is basically taking a sample of that skin that we're going to send off to the pathologist so they can then look at this slide here. And what you'll see on this slide is a bunch of little blue areas and some little things that look like strings. Those strings are actually nerve fibers. And so you count them up. And depending upon how many you count, that will tell you whether or not there's a normal or abnormal amount of nerve fibers. And then you get a test back, or the comments, which you see on the bottom there, that says, you know, here was the number that was acquired, and this is abnormal, normal, or whatever the case may be. So these are important to know because that's a different pathway of treatment if you have small fiber neuropathy. Now, getting back to diabetes and what causes diabetic neuropathy. Does anyone here know what causes diabetic neuropathy, other than eating too many donuts? Okay. Well, yeah, so what happens is when you get all this sugar into your body, it has to go somewhere. And where does it wind up going, other than the organs that it's supposed to go through? It goes into your nerves. So what happens is the glucose level then turns into sugar water, which is called sorbitol. That sorbitol then gets sucked into the nerve. And then when it's in there, now the nerve just keeps pulling more water into the nerve because it acts as a gradient. And then you get fibrosis because the water has nowhere to go and you have all this extra sugar in there. It basically forms scar tissue. And this scar tissue then squeezes on the little nerve blood vessels in there, and then you're not getting any nutrients to your nerves. And so once that nutrients is lost, the nerve starts to die, and you get more and more scar tissue, and it just keeps going on and on. One of the other things that happens too, and it says here where you see reverse compression. So if you have a tunnel where that nerve travels through, and my finger's the nerve, and you're coming into this tunnel, and that nerve is swollen, and now that nerve is the size of my two fingers, it's harder to get into that tunnel. Now that tunnel is going to squeeze that nerve and again cause more constriction, which reduces the blood flow, which causes more nerve damage. So it's a cycle that kind of never ends, really. And that's why it's so important to maintain your blood sugar. But it's also important sometimes that we have to look at the tunnels that they travel through and determine whether or not we need to do something about that, which I will explain shortly. So this process of damage is called glycosylation. And the double crush theory is basically saying that if the nerve swells against an area that has no ability to expand, you get a double crush. And in diabetics especially, the collagen is not as good, and so it will even shrink. So you get shrinking surrounding tunnel and expanding nerve equals neuropathy. And ultimately leads to demyelinization, which means the sheath that we talked about earlier, the myelin sheath, starts to deteriorate. And when that deteriorates, your conduction velocity of your nerves, meaning how fast they conduct thoughts from your brain to your feet, start to slow down, and that gets worse and affects the nerves in all sorts of different ways. So the first ones to go are those large fibers, or A beta fibers. And the small fibers I talked about momentarily ago are the C fibers, and they're the small fiber neuropathy. So again, we see here a cross-section of a nerve. This is basically what a nerve looks like with all its little millions of axons in there and cells that transmit all the information and are allowing me to speak right now. And you see these little blood vessels that are in there as well. All those little blood vessels, again, it just takes a little bit to cause damage to them. Not much at all. And then, as I talked about, there's all this fiber degeneration and scar tissue that happens. And this is just another way of looking at the cross-section of the nerve and why it's important to have nerve health. So, as I mentioned earlier about idiopathic neuropathy, if you go to a neurologist's office and they tell you have neuropathy and they put you on some drugs, they probably never check to see whether or not there's actually an entrapment in one of the nerves in your legs or your arms, which is not uncommon, unfortunately. And they will tell you, you either have diabetic neuropathy and there's nothing you can do about it, or you have idiopathic neuropathy and there's nothing you can do about it. Well, in a lot of cases, that's not true. So, in at least a third of those cases, something can be done. And so, mechanical neuropathy, again, as I indicated earlier, the most common being carpal tunnel syndrome, is an entrapment neuropathy, but there are many more. And again, it occurs from repetitive motion. Also can occur from if you're a heavy-set person and you're walking on your feet and your feet are deformed and it's stretching those nerves out. Those can also be problems. You know, a very common entrapment neuropathy that I'm sure some people have heard of is something called Morton's Neuroma, where you have a nerve problem in your foot. That's actually an entrapment neuropathy. It's not a neuroma. And that nerve is getting tethered against a piece of anatomy between the bones. And many people cut these nerves out. Not a good idea. They don't need to be cut out. They just need to be released from their compression, just like in carpal tunnel. So as you can imagine, if you look at this foot here on the top, before it's corrected, all the structures on the inside of that foot where that arrow is are being stretched out. Now, most people, when they see this as a physician, say, oh, wow, that's a really bad flat foot. They have a bunion deformity, and they must have tendinitis with that too, and probably arthritis. But they never mention the nerve that runs right behind where that blue line is. And so patients often complain of a lot of pain, and the doctor goes in and fixes the foot, like you see on the bottom, and now you have a straight foot. But they're still complaining of pain because that nerve was never addressed. And so again, the point is, always be thinking about that nerve. And in this particular picture here, again, as I mentioned in my opening statement, that the diagnosis of nerve pain is mostly by history. Nerve pain is burning pain, especially at night. And people want to know, well, why does my neuropathy hurt me mostly at night? Well, here's a sort of a simple answer. During the day, we're all busy, we're getting stressed out, whatever's going on. You know, it's like a highway. You know, if you're on the highway in rush hour, all you're doing is concentrating on making sure you're driving straight, and all the rest of the stuff is background noise. But then if you're driving on a road by yourself in the middle of the night, you hear everything, you see everything, everything's quiet. That's the same thing with the nerves. You're walking, you're moving around, your joints are moving, your tendons are moving, and everything's kind of combined together. But when you're sedentary, now that nerve says, hey, I don't like what you did to me earlier today. You were ignoring me. And now I'm going to tell you I don't want to be ignored anymore. I'm just going to keep telling you it hurts. It hurts until we start that cycle again and you ignore those nerves. So that's one of the signs that you're having a neurological problem. And then the physical exam, there's a bunch of stuff that we go through to determine, is it an upper motor neuron lesion, meaning coming from your brain, or is it below the brain, spinal level? There's certain tests, you know, can you feel hot and cold? Do you feel vibratory sensation? I'm sure a lot of you have maybe visited a podiatrist or a nurse practitioner, and they take those little Semmes-Weinstein monofilaments out and they touch your foot with it to see if you can feel it. Most of those are actually garbage. They have been around for so many years, and there's studies, and I think I have the slide in here that shows that it is garbage, and I'll explain why, and if not, I'll just kind of explain it. This is something that most people don't think about when they think about neuropathy, is hormone imbalance. So hormones are very important, and they actually, cortisol is one of the more important hormones for your brain. And since we're in the brain center here, I think it's very appropriate to mention that if you have a chronic pain, the cortisol level in your body actually drops. And so if that drops, it just potentiates the pain in your body, and you have chronic pain. So anyone with chronic pain that's had it and they have insomnia and certain signs, we like to check their hormone levels to make sure that they're appropriate, because if not, just getting their cortisol levels back up to normal can actually get rid of a lot of their pain without having to take narcotics or anything of that nature. This little test up here called the Mthfr test, again, something newer. They used to use this enzyme test for looking at cardiac disease. They found out that it wasn't so accurate in cardiac disease, but it does indicate a lot of people with neuropathy actually have a deficiency of this enzyme, which is methylene tetrahydrofolate reductase. Why do you think we call it Mthfr? It's too hard to say that every day. So that enzyme, when it's what's called homozygous, meaning you have two copies of it, usually that's not a good thing as far as having a neuropathy in your body. And so this enzyme is very important in converting homocysteine to methionine, which is very important in nerve health. So we can discover this and put you on medication to try to help with this. So I told you I would tell you about this little monofilament and why it's garbage. Well, there's a picture of it. I'm sure many of you have seen it in some form. And so that number up there, that 5.07 monofilament, measures pressure when you push it at 65 grams per millimeter squared. So what does that mean? So up to 65 milligrams meters squared, the patient will be safe according to that filament. If you test for that and you're okay with that, you should not have an ulcer or be at risk for one. However, there's studies that are documented and well known that show it only takes 4.3 grams per millimeter squared to cause an ulcer. So you do the math. If that's testing at 65 and it only takes 4 for you to start getting an ulcer on your foot, why would you waste your time with that? It's garbage. So anyone who's using that and telling you that, oh, you're okay, I would question them and say, Dr. Bregman said that thing is a piece of junk and you should never use it again. Okay? And I'll accept all the hate emails I get from my colleagues. That's okay. I will educate them, and I'm totally fine with that. So what other diagnostic testing can we do for people with neuropathy? Well, there's blood work, of course, and a lot of times we will order blood work just to make sure, especially if the primary care physician or neurologist hasn't gone deep enough to look at certain things. Nowadays, you hear the term pre-diabetic. Maybe you've heard the term metabolic X syndrome, which is kind of like prediabetes. These are all sort of metabolic conditions that can cause you to develop neuropathy, and it's sort of a wake-up call. It's kind of like if you're gaining a little too much weight and your pants aren't fitting anymore, or you got to open up your belt buckle. Well, that's what kind of like prediabetes is. It's a wake-up call that you better start sticking to the plan. And there are a bunch of other things that can be done to test for neuropathy, and we as physicians should know all of them and understand them. It's not for you to know, but it's for us to explain them to you. Electrodiagnostic testing. Has anyone in here had EMG NCD studies done on their arms or legs at all? Okay. So it's somewhat controversial in actually how accurate they are for certain things. When you're talking about the lower legs, they're pretty inaccurate and unreliable. I would not rely on their testing results for looking for peripheral neuropathy. They're very good at radiculopathy, which means looking for back problems. They're good at injuries where you think the nerve may have been cut or severely damaged. But when looking for stuff in the legs, not very accurate and very user-dependent. They are a little more accurate in the upper extremity, the arms, like for carpal tunnel syndrome and things of that nature. But by and large, they are not very accurate. So I do a lot of surgery on people with neuropathy because I believe they have nerve entrapment, and probably 20% of them have a negative EMG test, and I operate on them anyway, and they get better. So this just kind of proves that EMG testing is not very accurate. It also depends on the person who's doing the test. There's a lot of variability in the person who actually, the tech who's actually doing the test, where you stick that needle in somebody. So why, this is just highlighting some of the things that I just said, but again, very high false negative rate, meaning if it's negative, doesn't mean you necessarily don't have whatever you're looking for. It doesn't really correlate with the symptoms the patient's having. That's why when I say, if I see patients who I think have a nerve entrapment in their leg, and it sounds like a duck, it walks like a duck, and then the EMG test comes back negative, I don't use that. If it comes back positive, then I feel good. But when it comes back negative, I just sort of double check everything to make sure that I'm right. It's also painful, and it's also very expensive. The neurologists make quite a bit of money doing these things. I think well over $1,000 a pop. So it's also it's not as sensitive to early signs of neuropathy. So things don't show up on an EMG NCD study until you've had a problem for quite a while. So what are the goals of treatment with neuropathy? Obviously we want to figure out what it is so we can treat the underlying cause first, right? If we don't know that, we're just, giving you Lyrica or giving you Neurontin or some other drug to cover things up. And again, that's usually you got diagnosed with idiopathic neuropathy. We all know what I think about that. Next, once we identify it, we want to get you feeling better. We want to alleviate your symptoms. Now, I will say, I'm an advocate for medical marijuana. I think it is far superior to narcotic medication, and as you know, in this country we have a very bad narcotic problem. And medical marijuana, when used properly, is a great pain reliever and has a lot of other medical benefits. And I'm hoping that with the passage of our recent law, now we'll focus on more of the education of it, and there will be more education of not only the public, but also the physicians who may shy away from it for some reason. And then once we've gotten rid of your pain, we want to help you because we can't cure your neuropathy a lot of times. The sensation part of it, the feeling part of it, we can't always help. We can try, but it doesn't always work. The pain we can usually help with. We can manage it or even get rid of it. But the sensation part and the balance part, that comes with gait analysis, looking at your biomechanics and understanding what we can do to help you walk better and avoid the problems that can come with having these problems, like falling and breaking a hip or developing ulcers in your feet. So again, as I mentioned earlier, these quote incurable neuropathy cases, what are people typically doing? You know, the treatment of choice in many physicians' hands and it has been narcotics. A lot of times if you go to a pain specialist, they'll do spinal blocks for you or give you injections. Gabapentin or Neurontin actually works pretty good, but it does have some side effects. Amitriptyline is a very favorite drug of many neurologists, and amitriptyline unfortunately has a lot of side effects. So if you're taking amitriptyline and it's working, very often you'll be on 3 other drugs to counteract the side effects from the amitriptyline. So that doesn't sound like such a good idea for me, but sometimes it's necessary. And then topicals, compounding medications, can work very well actually. I've had patients who've done really well with compounding, but a lot of times insurance companies won't pay for it anymore because it was abused for the last 10 years. And so you have to be willing to pay cash for these things a lot of times, which is unfortunate, and they're not inexpensive. Other forms of therapy for people with neuropathy and chronic pain include psychotherapy. I think this is important, especially in people with chronic pain. You get depressed when you have pain that never goes away, and I think this can affect your whole family. And they don't appreciate how much pain you're actually experiencing, and so it's important to manage that from a mental standpoint. There are certain amino acids and herbal remedies that can be effective. There are drugs that diabetics take to help improve their sugar and regulate that, and they're always changing. As I said, the drug companies love diabetes, makes them billions of dollars every year. And then there's laser therapy. Laser therapy can be effective. It's hit or miss, and it certainly can't hurt you. And it's a cold laser. You don't actually feel the laser. You know, this is a typical patient with a problem from their diabetes. We see this every day in our office. This is someone who ignored their foot. And this is what happens when you don't pay attention to things. This was actually a patient of mine that I saw many years ago when I was practicing in Boston. And he was a 42-year-old male. Came in with a swollen foot. He was diabetic. He wasn't taking care of himself. And I said to his primary care doctor, I think this guy's got an infection in his foot and needs to go to the operating room. He said, no, we'll just put him on IV antibiotics for 4 weeks. Everything will be fine. As usual, I ignored the primary care physician, and I popped this open in the operating room, and all this pus just started pouring out of his foot. So can you imagine how long it would have taken for all those IV antibiotics to pour in there and try to solve that problem when all it needed to do was be drained? And so this is why we have to question things when they go on. You don't just, you want to take your word for your doctor, but sometimes you can't. And that's why specialists exist. So if you have a foot problem, I probably wouldn't let your primary care physician deal with it. I would ask for a referral to a specialist. This is just showing the typical diabetic neuropathy treatments, drugs, narcotics, all the things I just talked about. And this is the whole idiopathic neuropathy pathway, which again is the most common seen by specialists, because if a primary care doctor or neurologist cannot identify what the problem is, and they say you have idiopathic neuropathy, then they say, well, go see someone else because I can't figure out what's wrong with you. And so we see those people. And so those people, as I indicated earlier, often have an entrapment. And there are various areas in the body that can cause entrapment. And as I indicated earlier, let's say you have an entrapment in your arm or your leg, and the doctor sent you for one of those painful, expensive EMG tests, and it came back negative. Whoo boy, you are in trouble, because now you're off to the pain doctor, because they don't know what's wrong with you. And so now you're going to get medications, injections that don't help, that only give you temporary relief, and you could be lost in the pain management zone for 10 years until you somehow wander into my office because you heard about me. And so I think that you have to ask questions, and pain management, you know, if you haven't seen a specialist in nerve, then you need to, whoever that may be. And I can diagnose a nerve entrapment in a leg in 3 minutes. I don't need any fancy testing. I don't need to send you out for stuff. My hands can do it in 3 minutes because I've seen it so many times, I understand it, and when I hear from it. And again, it's very often mistaken for poor circulation. You know, if someone says you have poor circulation, or you think you have poor circulation, but you really don't, it's probably a nerve problem in most cases. So what are some non-surgical treatments of neuropathy? What do we do? And this is, again, some of it's repetitive, as I talked about. Gabapentin is the most common that I use, also known as Neurontin. Lyrica is the sister drug of Neurontin, and the only reason Lyrica exists, other than to make the drug companies more money because the patent ran out on Neurontin, is because the dosing is easier, and you have to take less of it. So it can be tolerated more than Neurontin, which is much cheaper now. And as I indicated earlier, I think medical marijuana should and will be a much better treatment option for people with neuropathy. And then these other drugs that I mentioned before. Medical food or vitamins, there are certain B complex vitamins and things that work synergistically together that can help with neuropathy. Making sure you have good nutrition is always important, no matter what state you're in. And so I think that's very important to always make sure you're as nutritionally balanced as possible. And if you can't for some reason, you should probably be taking some sort of supplements for that. Topical pain creams, again, as I indicated earlier, they work really well in some people, and some people they don't work at all. They generally can't make you worse. And if it's something you want to do in lieu of taking medication, I certainly would ask your physician about it. And laser therapy, it's 100% safe, it cannot hurt you, and it's about 80% effective, meaning you'll get something out of it. I would say probably half the people would continue taking laser therapy because it's helpful. It can help them sleep better, it can help reduce pain, it can help increase your sensation, not a ton. But one of the things that helps even more, that's probably 5 to 10 times more powerful than using laser, is what's called neurogenic electrical treatment. Basically, you're applying an electrical field to your arms, your back, or your legs at a certain wavelength or wavelengths in order to induce your nerves to get more blood flow to them and regenerate. And so we actually do that in our office, and that's something that I'm working now with a company that we're going to bring it to Las Vegas at some point to really help people with neuropathy and other sort of diseases that affect the nerves. Is completely non-invasive and really has some good data and good studies out that show that it can be effective at helping people without surgery if it's not indicated to have surgery. And as I mentioned earlier, hormones and pain, you know, if your hormones are off, you're never gonna get right. So if you have chronic pain, take-home message for that is get your hormones checked. Because especially as you get older, your hormones, they decrease, and some people need more to help them out. And this is a typical hormone panel that I would order on a patient if I thought they were having problems. Your pituitary, your adrenal glands, your brain, you know, the pregnenolone is actually like the neurosteroid of your brain, keeps it happy, testosterone, progesterone, all these are important to check. But if you only had to check 2, you want to check your cortisol and your testosterone level. And that's male and female. But cortisol is number 1. If that thing is off, you will not be in good shape. And there's a whole protocol. This slide's more for doctors on how to treat it and what dosing you should give and get someone feeling better to get them back to normal. A lot of times we'll just send them back to the diabetologist or the endocrinologist or even the primary care physician to say, hey, you might want to do something with the cortisol in this person. So my favorite part to talk about is surgical management of nerve problems when you identify that there is a nerve entrapment. And so a lot of times you can do nerve releases. And there was, I'm going to skip forward to this right here. So this is about a month old, this little thing here where it says diabetic neuropathy may benefit from nerve decompression. Well, the thing I don't like about this, and again, this was put in a magazine, it says may benefit. The answer should be will benefit. I think it's a little misleading. So 30% of all people with diabetes will have nerve entrapment, meaning there's a nerve being compressed in their leg, or more than one nerve being compressed in their leg. It is now, without a doubt, a fact that if you identify compression in someone with diabetes, you must operate on it and fix it. It's not a, well, maybe I should have it operated on, or let's think about it. No, you get it operated on, because every day you go with that nerve being squeezed, it's causing more and more damage and allowing you to be at risk for ulceration. And so they did a study where they basically blindfolded the doctor to what was going on and the patient, and they made incisions on both legs. And on one leg, they actually did the surgery, and the other leg, they did not do the surgery. So it's sham surgery, which is what's called a level 1 study. And that level 1 study proved that if you do that nerve decompression on those patients who have a nerve entrapment and diabetics, not only does their pain get better almost immediately, their sensation improves, and their risk for ulceration goes almost to zero. So this is something that you're going to hear about a lot in the future as it goes on. That's kind of what this little slide on the left says. But there's a whole study on that. So this is a patient of mine that I am operating on the common peroneal nerve, which is up by the knee here. That nerve is very frequently compressed and entrapped on diabetics, but also other people. In fact, that nerve is also responsible for a lot of back pain. I have operated on many people, after operating on that nerve, their back pain is gone because it got misdiagnosed. That nerve radiates up to the back and vice versa. Now, everyone with back pain doesn't have this problem. I don't want you to think that, but it's very easy to figure that out. Usually what I'll do is I'll inject that nerve and have them come back, and they tell me if their back pain got better. Then we operate on that nerve in a simple 15-minute outpatient operation. This area is the tarsal tunnel, which is the ankle area of the foot, and this is just showing a little bit of a schematic of what you're about to see, hopefully on a video if this works. And sorry if it's near lunchtime, but this isn't too gross, I don't think. Let's see if that works. Okay, so right here, I basically have dissected open, and I don't make this big of an incision anymore, but I'm down into the heel is at the bottom there, and the scissor is just showing you this ligament that I'm about to cut. You can see that white, it's under the muscle there. All that white tissue that I'm now cutting has been compressing the nerve in that foot. By releasing this actually restores the sensation to the foot and relieves pain, so you don't have, you're almost never going to get an ulcer after having this, as long as your foot has a relatively good structure. And once we're finished here, we just close this up, and you're able to walk on this immediately. So there's no being down for any long period of time. So what can you do sitting there in the audience, and what can anyone do? Knowing full well that 30% of all diabetics have this entrapment neuropathy, we should be telling them they need to be examined by someone like me, a specialist who can identify it, and if they have it, have the surgery. If I said this 10 years ago, I was crucified. The neurologist would say I'm crazy. You can't be operating on these people. You can't help them. Well, now it's been proven that I wasn't crazy. And that's why a lot of people came to me and had surgery by me to have this fixed. So I think that's important to understand that it's, even though it's surgery, it's elective surgery in most cases. It's very rewarding and has a very low downtime and very low risk. This is another example of that electrical therapy I spoke of, and you can see the machine there on the left. And it's just some probes that come out of the machine, and then there's, you can't see it on the slide on the right there, but there's, this is where we're injecting some local anesthetic into the leg to help even increase more blood flow and get more healing of those nerves. And something that's exciting that's coming out now, and I'm sure you've all heard about stem cell therapy and all this stuff. Well, we're actually thinking about combining this therapy with stem cell therapy and getting even 5 times the results. And that's coming down the pipe, and that's something I'm getting involved in, and probably in the next 6 months or so, you might hear about something like that. So I think it's pretty exciting, and I think there's definitely some data that shows that it works, and it's important. Heel pain. I'm sure half of you in here have had plantar fasciitis, right? Everybody, yes, plantar fasciitis, heel pain. So of the half of you, or however many of you have had plantar fasciitis, what you probably didn't realize is that part of that pain you were experiencing was nerve pain. Somewhere around 70% of all, quote, plantar fasciitis heel pain has nerve pain involved in it. And unless someone knows how to evaluate that, you're going to continue to have pain that's been diagnosed as plantar fasciitis for the rest of your life. People come to me all the time, I've had plantar fasciitis for 10 years. No, you haven't. If you've had plantar fasciitis for 10 years, you've either had a really bad doctor, he could have been blind and or deaf, or you have a nerve problem. So it's usually the latter. It's usually nerve problems, and so it's very easy to identify the difference between the two if the doctor's willing to take the time out to look for that. And then what is it? It's that tarsal tunnel syndrome that I spoke about that runs right next to the heel, and there's different nerves that affect that, and that's my job to figure out what those nerves are and how to fix them. So today we learned about neuropathy. You probably learned that there's tons of it, and it's more rampant than you would ever think. And I hopefully have educated everybody here in the audience about what they need to ask about and see and seek. Don't rely on your neurologist to diagnose you. Ask questions, see a specialist other than them, because believe it or not, there's some of the neurologists in this state who all they care about is doing EMG and CT studies on you as much as they can. I'm not saying that's many of them, but there are certain small percentage that that's their sort of, quote, bread and butter. And surgery is extremely successful. 85–90% successful when you're operating on nerves, as long as you know what you're doing. And then there's different reasons for this. So I think that is the end of my lecture. And as we can see, this reminds me that it is the end of the lecture. So I can probably take some questions for the next 10 minutes. There's a microphone here that I think you'll have to use so everyone can hear you. I don't know if we can get someone to pass it around or if you had to step up to the mic, but I want to make sure everyone hears your question.
I can answer or ask a question and they can be heard. The compacted nerve surgery, is that covered by insurance and Medicare?
Okay, the question was the release of the compressed nerve covered by insurance, and the answer is yes. Medicare, all insurances. Green shirt, sir.
I saw a flash on the screen, but I didn't get a chance to read it. It said something about plasmapheresis.
Yes. Plasmapheresis can be used in the treatment of small fiber neuropathy because, again, there's no cure. They also use it in other kinds of neuropathy as well, in certain other diseases. I have zero experience with doing plasmapheresis. I only know about it because I did some research on it, and I understand that it's usually instigated by neurologists or other specialists. And so the whole theory behind that is to get into the autoimmune aspect of things and try to work on that. Where am I? Oh, perfect.
About 2 years ago, I could run. I was an exercise instructor. Anyways, the last 2 years, I have not been diagnosed with neuropathy. I'm having a hard time walking. I have gone to my regular doctor, he sent me to a neurologist who did all the probing and needles, the tasering. He's here to talk to Dr. Yu, who is useless. 4 times I've gone to him. He said, I can't help you anymore. You have a monster in your body. And so he sent me to another doctor here in town, Dr. Bessie Chang. So they sent all of my stuff to them, and she refused to take me as a patient. I've had numerous blood work, I've had brain exams, I've had every kind of test you can think, and every day it is getting harder to walk. And nobody has ever mentioned the surgery. I can't even find a doctor that will take me.
Well, I will take you.
I'm serious. I I cannot believe they told me she was a doctor and everything like that. I'm really going out there. I'm 67, and I'm having such a horrible time.
Well, you come visit me, and I will tell you if you need to worry about any of that stuff that they said, because I will evaluate you, and
They use that word video.
yes, like I said, some of them are idiots. And now, granted, it's possible you do have a true idiopathic neuropathy, but they never checked you for what I will check you for.
I've never had surgery in my life. I've never been in a hospital.
I promise you that if you come, whether it's surgery or something else, we can help you. Okay? You're welcome. Sir in the front row.
Would you give us your telephone number and your address?
So, sure. For those who want to write it down, our telephone number to the office is 702-878-2455. And our office is located at West Sahara and Rainbow Cimarron, that area, right across from the Hyundai dealer. That's me. In the back, young lady? No. So the question was there an age limit on doing surgery, I assume, or treating this? And the answer is no. It is harder to treat the longer you have had it, unfortunately, because of the damage to the nerves for so long. But depending upon the examination, I can tell you whether or not you'll get relief from it. As you can see, my lecture is on point with what happens to people. They get lost in this world of neuropathy. You're welcome. Sir?
Can damage to the large fibers, the small fibers, or myelin sheaths ever be reversed?
That's a good question. Can damage to nerves be reversed? The answer is yes. So it depends on the cause of it. If it's compression and you remove the compression, the nerve will eventually heal itself, yes. If it's certain other damage caused by, let's say, radiation or something of that nature, it's much harder to heal from that damage. If the nerves are just kind of hibernating, they're not completely dead, you can always, once you restore circulation to them, they can reverse the damage, absolutely. But if they're dead and they're just, they're dead.
Can you elaborate on the medical marijuana, CBD?
Sure. So medical marijuana, there's CBD and then there's the THC. THC is what gets you high. CBD does not get you high at all. That ratio between CBD and THC is what's important in pain. You should try to get the lowest level of CBD that helps you, basically. So some people do great, they don't need barely any THC. Some people need a lot, depending upon how much pain they have or what the pain level is. So any good dispensary should be able to tell you that information, and it comes on the packaging as well. What's that? Oh yeah, so most of your ointments are made up of CBD. And again, that's sort of like the topical medications that I talked about earlier, the compound medications. Some people do great with them, and some people don't get any relief with them, but it certainly can't hurt you.
I've been using CBD for about 3 months, and I can honestly say that it helps.
That's great, yeah, and like I said, I think it's so far better to use that than narcotics. Sir?
Is there any form of medical imaging that's good for finding entrapment?
Yes. Unfortunately, most insurances won't pay for it, and there are very few places that do it. So the question was, is there medical imaging to determine whether or not you have entrapment? The answer is yes, and that answer is MRI neurography, which isolates the nerve with a special MRI, and you can see if it's kinked or entrapped or swollen. There is no place here in Las Vegas that does it. The two closest places are Arizona and California. Sir? So, yes, I do have an opinion on that. If the problem is at the back, and that is the source, then injecting anything in there to reduce the swelling of the nerve in that region can be helpful. Whether it's steroids or amniotic tissue graft or stem cells, whatever the case may be. Now, sometimes the back and the leg are the problem, and they overlap or they confuse each other. And so oftentimes I'll see people with back problems and leg problems, and I'll treat the leg first. And a good portion of times they get better in their back as well. And so it's much easier to make a little incision here and release a nerve than it is to go in and do back stuff. So that's usually the pathway that we go with that. So it really depends on where. If it's true back pain, then yes, can be very effective. Sir?
What's your opinion on use of infusion treatments with Rituxan?
With what?
With Rituxan.
Rituxan. I have to know the generic of that.
Anyway, it's sort of like chemotherapy, but without the chemo.
So let's just talk about infusion therapy in general. I can't speak to that specific drug, but I think if you can, there's two branches of infusion therapy. There's medical and then there's homeopathic. And I think that if you take medical infusions, they have a lot of side effects. A lot of damage can be done. But the homeopathic route, where you're getting stuff that's kind of naturally done, a lot of homeopathic doctors do that. I think there's at least the people that I've talked to have had great success in using that. So I think you just have to find the right doctor, and I'm not sure there are any here necessarily.
My wife has tremendous tingling numbness from the knees down for about 3 years. We've gone to Dr. Liddell over there near you.
Yep.
With sensory,
Yep.
perhaps sensory neuropathy.
Uh-huh.
He had her all wired up maybe 20 times. Did absolutely no good whatsoever. Best Shang, as this other lady was mentioning, could not come up with good. Went to St. Rose Community, tested her extensively, and it was not pathology, it was not Parkinson's, it was not the muscular dystrophy, it was a whole bunch of things that it was not, but we can't find what it is.
So it's idiopathic at the moment.
Numbness and balance, no pain, fortunately.
Those are very difficult cases to deal with for me, because when I have someone coming in with pain, I get very happy because I can usually help them. When it's just neuropathy and balance issues, it's harder to treat. I'm not saying it's impossible. So it's still worthwhile to be examined for nerve entrapment, because none of those people that you mentioned do that. It's still worth being examined. And then if that's not an avenue that I can help with, down the road, again, what I alluded to earlier with doing electro treatment with stem cells might be an option. But for now, again, unfortunately, as a physician, I want to help 100% of the people that come to me, and I just have to realize sometimes you can't do that. But it's certainly worthwhile to be tested for entrapment.
Thank you.
I can still stick around for a few minutes, so I'm fine. Yes?
Will you always use a diagnostic tool for the nerve entrapment, aside from?
So yeah, my other diagnostic tool that I use when I'm trying to figure out if someone has nerve entrapment is my needle with anesthetic in it. So if someone has a nerve entrapment, almost always I will inject some local anesthetic into that area where the pain is. And I will tell them, go do whatever you want that normally irritates this, come back next week or a few days later, and if you had a positive response, which is something I would do to your wife, if there was a positive response, then I would go ahead and operate. And sometimes I'll repeat it if it's unclear, but and a positive response is someone telling me they had hours of relief minimum and it got at least 50% better. So she needs the braces to assist her walking because of her neuropathy? Okay, so that's severe, obviously, but it doesn't mean she cannot be helped. And again, if she has entrapment, and depending upon how long it's been and if it's active, let me put it this way. So if someone's had a nerve entrapment for many years, 20 years, 15 years, whatever the number is, and I do my test and I get basically like I'm testing a block of wood, I cannot help that person. At that point in time, I tell them, listen, the next step for you is to try some electrotherapy, like your wife was trying. Try that. Hopefully it works. There are different versions of that. If that doesn't work, then and you know, it's a walking issue, then I say, you know, you have to have braces or some sort of assistive device. But if it's pain, my immediate would be to go to medical marijuana at that point.
How heavily booked are you?
How heavily booked? Not too bad, a couple weeks. Let's go here first for a second.
My question's related to hers just now.
Sure.
Which is, hey, look, we'd love to see you, but you know, we're often limited by our health plan. What's the best way to see you in terms of our health plan? What should we do with our health plan? I.e. switching or within the health plan to see you?
So there's only there's only 3 people who do what I do in the whole state. So you can probably say to them, listen, nobody else in my health plan treats this. This guy has written articles on it. He's the only guy. No one's been able to help me. And if you don't let me go see someone that can potentially help me, I'm going to sue you. Yeah, say that. I don't know what your insurance is. I think we do. I know I've seen Humana patients, but I'm not 100% sure. I'd have to have, maybe Denise can check up on that if we take the insurance of these fine people.
One other question. I'm on
Gabapentin, yep. How much are you taking?
300
Just 300 a day? So just a quick word about that. The dosage for gabapentin to actually work on neuropathy is 1,800. So you might as well not take it at all. Anyone who's taking gabapentin below 1,200, it's useless for neuropathy. Yes, now, occasionally, and it could be placebo, someone will take the medication at 300 or 200 or whatever the low dosage is, and they'll say it's working. The reality is that's placebo. It's actually not doing anything to the function.
Anyhow, can you take the medical marijuana while you're on that?
Yes, you can. The question was, can you take medical marijuana with gabapentin? The answer is yes.
I have neuropathy in both feet. What are the odds of having nerve entrapment in both legs?
50%. 50% of the people I see with neuropathy have it in both legs. Sir?
Is there a correlation between a neuropathic condition with exercise that increases circulation? I've read that.
So exercise is great for anything pretty much, but certain exercises can actually make entrapment neuropathy worse. Certain. Not most of them. Anybody else? Yes, in the back? Oh. Oh, that's great. So basically the question was, and I did speak about this earlier, about how important nutrition is, not only with diabetes, but with pretty much everything. If you don't have a good foundation in your nutrition, you know, you're fighting an uphill battle. So apparently there's an avenue here for you guys to avail yourselves of a nutritionist and get some education and make sure you're doing what you're supposed to be doing. I think I'm being hexed off here, but we'll give you one more question. So the question is, what does medical marijuana come in? What forms does it come in? Well, of course, I'm sure you're all aware you can smoke it. You can vape it, which means you're not getting all the smoke in with it, and you have to use a special device for that. You can eat it, and that's probably, you gotta be careful when you eat it, because you don't know the onset of it, and you have to just kind of do trial and error if you're doing that. And then the other way you can do is sublingually, where you get put it under your tongue. That's a lot more predictable. And I think as we go on, you'll find that there are better ways and more accurate ways to utilize it. We'll certainly get to those levels where we can do that. And again, I think it's an important treatment for people who have no other options, certainly. Thank you.